Right, for those of you joining, welcome. We're going to give it just a couple minutes here, allow everybody a chance to get settled. Then we'll kick things off for today. I'm curious, anybody have anything exciting or fun for lunch? Got the team together, brought in something from outside. Hopefully nobody's microwaving tuna fish in the office. So I guess if your colleague or your coworkers got something gross for lunch, throw that in the chat as well. But what's for lunch today? Or are you just so busy and so hardworking that you don't even, this is your only break for the day and there's no lunch at all? Let us know. I don't have any prizes to give away, but PB&J. Sometimes that's just the easiest, most delicious comfort lunch out there. I think that's a great one. All right. Well, we'll give those who are still coming in a chance to get in and get settled. Here we got one more. Bubby's bread and butter pickled chips. I'll be honest, I don't know what Bubby's bread is, but it sounds great. Well, welcome in. Good afternoon, everybody. Thanks so much for spending your lunch with us at another Practice Advantage Lunch and Learn session. I'm Dr. Justin Manning, Executive Vice President of Professional Strategies here at Healthy Eyes Advantage, and I'm thrilled to welcome you in for this July Lunch and Learn. I'm joined today by Dr. Gillen Cockrell, who is the CEO of Williams Group, who will be talking today about one of, if not, I think, the most critical piece that we have to get right in practice if we want to be successful, and that is the baton pass. And that baton pass, is, as Dr. Cockrell is going to talk about, is not just Doctor-To-Optician, but it's any opportunity of transferring information and authority between and among the team members that you have in your practice. Before we dive in, just a couple quick things. Feel free to use the chat if you have any questions about Practice Advantage or the Lunch and Learn. If you have content-specific questions, please use the Q&A feature, as we will use and go over those at the end. For those of you who may not be aware of what all the Practice Advantage encompasses, there are three specific things. One, the Lunch and Learn series and this session that you're in today. The second component is the Practice Advantage podcast. So take out your phone, open up your favorite podcast app, Apple, Stitcher, Spotify, Google Podcast, Amazon Music, search all one word Practice Advantage and hit subscribe. Every other Monday, 25 minutes or less, we bring you business management tips, tricks, and strategies for your practice. And the third, and really the most important piece of the Practice Advantage, is the Practice Advantage program, which really is a platform for your success and how you can use your practice to live the dreams that you have for your life, your community, and your family and your patients. There's three components to the Practice Advantage program. One is an on-demand, complete start to finish staff and team training program, which gives you the opportunity to take well-established team members or somebody brand new to eye care and really upskill and train them in the ways that they need to be trained to be an effective team member for any position in your practice. There's a monthly strategy session with your Practice Advantage coach. And the third component is unlimited inbound consulting. So you can reach out Monday through Friday to your Practice Advantage coach for any question, any challenge, or any opportunity that you want to explore with them. So that's the Practice Advantage program. We're thrilled to have you with us again. I'm going to stop talking because you're not here for me and turn the virtual floor over to Dr. Gillen Cockrell for baton pass optimization.
Well, Justin, thanks for the kind introduction. And it's great to be here this afternoon. I'm going to stick fairly close to this slide so that we can get through the presentation and leave plenty of time for any questions that your members may have. Please don't hesitate to ask them, and I'll do the best I can to answer them. So let's talk just a little bit about the baton pass. We've heard about it our whole career. And starting with a bit of a snafu here.
You'll just go mouse over your screen. If you go to the bottom left of you go ahead and click on it, and then there you go.
So we can view that baton pass as something that's really a friend or a foe, and a lot of us are a little bit afraid of what really happens in there and a little bit timid about talking. So we're really all aware that kind of the transfer of the patient and the information regarding that patient, as Justin mentioned, are really critical factors in building and sustaining that patient experience that we're hoping to do. So let's take just a few minutes and talk about that and break down some of the components. So what is the baton pass? In my mind, it's really multifaceted and is made up of both the patient and the information regarding the patient, as we previously mentioned. So what's our goal? I think we all have pretty much the same goals. First one might be capture rate. Capture rate's kind of a benchmark that people compare a lot. And I can assure you that it's nowhere near as high as most of your friends tell you it is in their practice. And then influencing that patient experience, great component. And what about influencing the likelihood that the patient's going to ever return to your practice, which is huge right now and maybe always has been. And then what about maybe influencing compliance by the patient? And maybe that drives everything else. What does that baton pass really kind of consist of? Well, as Justin mentioned, in a few words, it's the transfer of the authority and information from one team member to the next. Well, let's put the emphasis on authority. And what does that really mean? And how do we really do it? Because once you're done with what you do, it's really about the next person. And if you don't spend a minute or two making them look stellar at what they're going to do, it distracts from the patient experience. So it might be from your receptionist to your pretest technician, might be from your pretest technician to the doctor, or the doctor to the optician. Obviously, there's multiple baton passes in that whole patient experience. So let's talk a few minutes about what might influence its success in supporting the patient experience that you're trying to create. First thing, is it important where the baton pass occurs? Well, I like to think of this as getting the work done where the work is done. And so in the case of the doctor to the optician, it might be arguably, I think arguably is, more effective if that baton pass occurs in the exam room. And there's multiple reasons for that. One, we're transitioning from a health evaluation to a perceived retail experience. The cost of the health evaluation might not be as discerning or disconcerting to the patient due to the fact that, generally speaking, it's paid for by a third party. When they get to the optical and their pocket becomes more involved, the ugly specter of cost rears its head pretty quickly. So what about keys to the baton pass? As we mentioned earlier, it's transferring that authority to the next person. And we'll talk about that just a little bit in the question and answer session at the end of the presentation. But also it's a vehicle for information exchange, and it might give the doctor another opportunity to reflect on and repeat their recommendations in front of the patient, so that you embed those thoughts in the patient's mind. It also obviously supports your recall and the effectiveness of your pre-appointing. Something we don't always think about is it really helping fulfill our mission statement with regard to maintaining the high standard of care and maybe the type of instrumentation, the type of eyewear we provide, special services like myopia management or macular degeneration, all those things. And then one of the key things, I kind of tend toward efficiency, is it keeps you from having to look for the next person involved in that experience, maybe the optician, maybe a special testing technician. In the end, all that experience is going to be impacted dramatically and affect the increase or decrease in your per patient revenue. So there's a lot of approaches to this, and approach that is slowly dying in optometry practices is that of the doctor walking the patient to the optical or the next place that they need to be. And I'm telling you, I've seen this hundreds of times, and it's fraught with so many potential problems that it's just almost too scary to think about. Some doctors have their scribe do it or technician do it. It's equally terrifying. Those those baton passes rarely communicate or transfer the information in the way that you would like. So let's talk about uh, the optical baton pass scenario. It's kind of the conventional whipping area. So at the very least, let's have it happen in the exam room while the recommendations that you've made to the patient are fresh in their mind. And it might require your optician coming to the exam room instead of you walking the patient to the optical, which all by itself is this huge step up in efficiency and may allow you to have more patient encounters in the day, which obviously influences the top line and bottom line at the end of the day. So maybe in the case of a clinical optician, the optician's already in the exam room, has the advantage of hearing all the reasons for the recommendations that you're making to the patient, and is maybe even involved in that discussion. In our practice, that resulted in a 25% increase in revenue on the same number of patients each day. As far as I know, in the practices that Williams Group helps and have implemented this approach, the lowest impact has been 15%, and that's to the top line. That's not the impact to the bottom line, because as you all, I'm sure, have already surmised, the bottom line is going to be impacted exponentially because you've already met your overhead. So the percentage that you get to take home or do spend some way of that last 15 to 25% is skewed fairly dramatically. So what hangs in the balance? Obviously, better or worse recall and pre-appointing, better or worse optical and contact lens capture rates, better or worse compliance to your therapeutic recommendations, which I want to talk just a little bit about in a moment, better or worse social media reviews, and better or worse overall patient experience. So back just for a moment to that compliance statement. Most of you are excellent doctors. Probably all of you are excellent doctors. And really, how that gets transferred to social media and the community at large is how effective you were in getting your patient to comply to your recommendations. Because if you recommend a treatment plan, I follow it and I get better, you're a great doctor. You recommend a treatment plan, I don't follow it, I don't get better, I leave out any of my conversations with my friends that I didn't comply. I'm just going to tell them I went to see Dr. Manning and I didn't get any better. So it can be a huge detriment to the reputation of your practice. So Justin, thanks a lot for letting me talk just a few minutes about this really important part of your patient experience. And I'd be tickled to answer any questions that your members might have right now.
Thanks so much, Gil. And I think this is just such a critical topic. And I love the way that you talk about transferring of authority, and in the way you communicate and pass that baton, it's empowering the team member to just continue the process and deliver a great experience and help patients achieve the outcomes that you want them to have, both from a retail experience, from a medical experience, and from a business experience in the practice. I think that's so critical. At this point in time, I'll open things up to questions. For those of you interested, if you have questions that you want to ask, please use the Q&A feature. All right, here's we got a good one. What about when you have a short-staffed day? This is a great question. 2 of 8 staff are out sick on a busy day, for instance. How do you address that?
Well, fortunately, I didn't practice in the COVID environment, and so I rarely had a short staff of that percentage in my practice. Even if I had, I had a goal my entire career of being a little bit overstaffed. The reason that I wanted to be overstaffed was I had to meet spikes in demand. So whether you realize it or not, you might have had all 8 of your people there, but maybe between 3:30 and 5 o'clock, when there's an increase in patient demand for people picking up eyewear, people picking up contact lenses, people calling in after work because of an issue, maybe you couldn't meet demand. So I was always a little bit overstaffed anyway, and that helped me meet those spikes in demand and grow my practice quicker. So but even if I've been caught in your situation, there are some things in my practice that I just wouldn't relinquish on. And one of those was helping my exam room. I did that by having my staff be unmercifully cross-trained so they could fill in really at about any point. I, I I'll expand on that if people would like me to, or people can definitely connect me. But I don't want to inhibit the opportunity for other people to answer questions.
Another question that just came in, I think that's a fantastic answer. What are the exact words you use in a baton pass? And perhaps maybe this is the exact handoff, and it's obviously going to differ based from patient to patient. But how do you really communicate?
Right.
Walk us through a little bit more specifics around your baton pass and the optical, called the optician handoff standpoint.
Great question. Thanks for answering that, because I kind of wanted to answer that when I was in the presentation and left it out. So thank you, whoever asked that question. So really, that transfer of authority is a really big deal. Obviously, I had clinical opticians in my exam room. Where I had them positioned in my exam room was important to me. I wanted them to be parallel to me. I really didn't touch a computer for many, many years. I really was positioned on the other side of the room. I didn't want my clinical optician behind me, looking subservient. I didn't want them back in the corner, looking kind of they were stalking the patient. So I had included them in the discussion of what the findings all the way through the examination. At the conclusion, when I was doing the baton pass, obviously we had already discussed all of the lens materials and types and things. So we'd done a lot of the heavy lifting. And one of my clinical opticians was named Casey. So I just say, Casey, Dr. Manning does a lot of near point work at a computer, and I want to maybe use a short corridor progressive for Dr. Manning. And I think I want to use XYZ lens. But you're the one who sees people when they come in with problems. And so is that really working as well as I think it's been working, or no? And I really didn't mind what Casey said. It's been working great, which validated my recommendation, or no, Dr. Cockrell, we're switching everybody to ABC lens, and I great. Thanks for not letting me foul that up, because all I really cared about in that conversation was that the patient understood that I respected my optician, and I wanted to build the patient's confidence in my optician, and then of course also it's really crucial to have something kind to say about the next person in line, whoever that might be. And so, I really began that conversation with, Dr. Manning. Casey is really one of the most amazing frame stylists that I've ever had the pleasure of being associated with. And she is extremely adept at using our digital measuring devices so that you'll get the best fit on both your frame and your lenses that is possible. And then I might follow it with asking that question. So really two components. One, the complement of the next person in line's ability to do their job. Two, ask them a question that shows that you respect their opinion. That's going to increase your capture rate dramatically, just those two things. One other quick thing. If whoever you have in your exam room, whether it's an optician, whether it's a scribe, whoever, you may ask them to do some other task while they're in the room with you. So when you introduce them to the patient, please think about how you do that. Don't introduce them as somebody who's going to be helping you manage the data input or be your computer tech. I always introduced them as, Dr. Manning, This is Casey Jones. She's one of my clinical care technicians. She's going to be assisting me in your examination today. So then whatever I asked Casey to do didn't create a distraction in the patient's mind, wondering if they were really up to the task. Whereas if I said, this is Casey Jones and she's my data input technician, but then I asked Casey to instill cyclogel in somebody's eye, they're immediately distracted and wondering, wait a minute, I thought she was a clinical data technician, and now she's going to put drops in my eyes, and is that above her pay grade? And maybe it's going to hurt, and I may be talking, but they're hearing nothing that I say. So those are the two critical things: the compliment, and then the question.
I love it. I from a psychology standpoint, what you just did when you have that specific approach, what you do is you change the perception, especially on the optical side. Now that individual is no longer a salesperson as the patient may perceive them, but a problem solver. And that breaks down the biggest barrier to really complying with that treatment plan. I love it. I'm going to read both these next two questions because they both pertain to staffing. So I think we can answer both questions in one fell swoop. The first question here, would you mind sharing about the number of staff members that you had in practice? Assuming a one doctor office, how many comprehensive exams per 8-hour day? So that's the first question. The second question reads, what about having one receptionist, one tech, and one optician, and the optician is busy on the phone or with a patient? They further went on to explain, I've been overstaffed before and find out of, say, 8 employees, 3 of them do the work. And so they found having 3 employees works best for me. So I guess two-part question around staffing, number of staffing, and making sure you have the right number of staff. And if you have a smaller staff, the optician's already busy, how do you approach that?
Okay, I'm just going to lay out a quick scenario. Let's say I want to work 4 days a week. I want to make a minimum of $400,000 a year take home. That's what I want to do, and I've got a $400 per patient revenue. I'm going to do 16 comprehensive exams a day, and all of the pathology and contact lens follow-ups or binocular vision follow-ups that go with that. So I might be seeing 16 comprehensive exams. I might be seeing another 16 of those follow-up visits of one kind or another, or some kind of pathology issue that comes through the door. So maybe 32 patients a day that I'm going to see total. If I really want to do that, and I don't have, and I'm not farming out any of my work, like I don't have a revenue cycle management company doing my billing, or I don't have some recall company doing my recall. I'm doing everything in-house. I'm to really make that fly, I'm going to need 7 people, and I'm going to need 7 people that are relatively cross-trained if I want the receptionist model. And I'm going to need 1 receptionist. I'm going to need probably 1 to 2 pre-testers. Everybody else is an optician or can do anything else in the practice. One of the ways I solved this was I changed the way I thought about hiring. I fell victim to the conventional wisdom early in my career of hiring for position, or this personality, you need this personality for this, or this personality for that. And I think that's really, really self-defeating. I switched from that model to, I hired people to work in my practice. I didn't hire anybody to be a receptionist or a technician or an optician or anything else. I hired you to work in my office. We have one job in our office, and that's to create the greatest experience we can for our patients and make their lives better. And that's it. And so answering the phone, no big deal. I obviously, even in a practice that I'm lining out, one receptionist can't answer all the calls. So thank goodness there's Bluetooth headsets. All 30 of our staff wore Bluetooth headsets because we wanted that phone answered in less than 3 rings. As the doctor alluded, there's generally somebody who's not with the patient. So anybody in our practice could answer the phone, do whatever was required from there. But also, gosh, those extra staff people didn't really know how they could contribute. In my opinion, they didn't really know how they could contribute. One of the ways they could contribute was being in your exam room and rotating through those patients. And because the most critical thing is the patient. So, man, one optician, one receptionist, and one technician would really restrict your practice flow. And I think maybe you just had a bad experience and maybe leaned a little too far the other way. And I'd be tickled to spend some more time talking to whoever that is about it, Justin, if they want to take some time.
Perfect. All right, we'll give it another minute or so if there's any additional questions. And seeing none. Well, Gil and I can't thank you enough for joining us and sharing some fantastic wisdom on the Baton Pass and how really to optimize each individual Baton Pass throughout the practice and throughout the patient journey. For those of you who are interested in learning more about how the PracticeAdvantage program can really truly help you live the dreams that you want your practice to provide for you, you can reach out to PracticeAdvantage at HEA2020.com. In addition, you can also learn more by going to the website there on the screen. Now, we did have another question come in, which is great. So I'll go ahead and we'll share that one here. What do you say to the doctor that says he cannot take the time to do a Baton Pass? I think it's a fantastic question.
Well, I think the doctor is thinking about the Baton Pass incorrectly. When I had the clinical optician in my exam room, the Baton Pass happened for my entire patient encounter. So if I had 20 minutes of FaceTime with the exam and my clinical optician is right there and I'm including him in the conversation, they're managing the data. They understand completely all of the recommendations that I made. I really didn't have to go out and do a Baton Pass anywhere else. So I created as many efficiencies as I could in there because I wanted to optimize, one, the patient experience, two, how my practice benefited from that patient experience in all those ways that we talked about.
It's a fantastic answer. I think, as you talked about at the beginning, by not effectively passing the baton, especially when it comes to the optical side of things, the capture rate's going to be lower. And therefore, you're not going to make as much revenue per patient. And then you're right, the doctor's ultimately going to have to work a lot harder to see more patients to generate where the practice needs to be. So it's interesting, and I appreciate your insight in that, because the Baton Pass actually will make you may not have to work quite as hard because your capture rate goes up, your revenue goes up, and you have a great patient experience and throughout the whole process. So
Justin, thank you for I'll take one more minute. I think I can do this in 60 seconds.
All right, I'll hold you to it.
Let's take the example of $1 million practice. And now I have a clinical optician in my exam room and my gross increases by 25%, $250,000. I've already met all my fixed overhead. Maybe I only have my cost of goods in there. So now my net might be 75% of that last $250,000. So just for taking the time to do that, changing the way I delegate, changing the way I utilize my staff, I just added $200,000 a year to my bottom line without doing anything else. I didn't see a single extra patient. That's the impact.
You're right. That was 60 seconds. All right. I got one more 60-second question for you. Can you do the Baton Pass? Obviously, the clinical optician in the exam room is the most effective and the highest recommended approach, but can you do the pass without having a clinical optician in the exam room?
Yes.
It's say less than ideal.
Yeah, yes, you can. As long as the Baton Pass is happening in the exam room, just have your optician come into the exam room. It's going to add a couple of minutes to your patient encounter, but just take the time to explain the recommendations you made, why and when you need to see the patient again, so you can increase not just your capture rate for the eyewear, but also whether the patient returns to your office again. Make sure that you do that in a complimentary way. Don't go over the recommendations 3 or 4 times with the optician, because the patient starts to lose confidence in the optician's ability, and the optician starts to lose confidence in you. You don't have to just hammer it into them, but just don't forget the two critical things. One, compliment their skills. Two, ask their opinion about the recommendations that you made. And then you're getting buy-in and validation from everybody in the room. It's very worth, it's very, for $200,000 a year, would you spend 2 more minutes?
Love it. Well, thank you, everybody. We do want to be conscious of your time and do want to keep these to 30 minutes or less. We will send out a follow-up email to all of you. Again, if you want to learn more about the PracticeAdvantage program, you can access us both ways there on your screen. We will also share the link to the recording. Dr. Cockrell, thanks again for joining us and sharing your wisdom. And for all of those of you who have attended, please be on the lookout for next month's event in the end of August. We'll see you all then. Thanks so much.
Been a pleasure. Y'all have a great day.